Okay guys, this is actually a response to a question that was posed to me about the difference between a high SMAS and a classic D-plane procedure. So I decided it would be easiest just to draw it out. So first of all, I wanted to show you my incisions because I think it's helpful to understand how I plan an incision. So this incision is placed around the bottom part of the temporal tuft. I try to avoid the incision coming up here unless I've got to do a brow lift in this zone because this area doesn't heal quite as well in the vertical plane. And you can see that they're all sort of curvilinear. The other trick here is that you want to go forward. They call it a hockey stick. So you want to try to avoid a straight down incision because this straight down incision, honestly, most people won't even see it, but other surgeons looking at my work would be able to tell. So I try to create a hockey stick going forward, then down. This is just a slight curvilinear design. It goes into the back of the ear, and then then it comes down a short distance here. The trick is not to go too far down. I try to do this at what's called the helical root, so as it comes back, this incision is well healed. So that's a quick summary of incision. So the high SMAS, as you may have seen in my video, superficial musculoapparatic system, is the collagen tissue that is being elevated upwards to be pulled up. And as I talk about in my separate video, the deep plane versus the SMAS lift. A traditional SMAS lift, basically you lift up the tissues through this incision and then you just pull those deep tissues up. You actually never enter the deep plane. So the deep plane is a plane that sits between the parieto-masseteric fascia and then the superficial musculoapparatic system. So between these two planes sit ligaments. The ligaments that sit there are the ligaments that when you pull on the SMAS, they don't go up, they stay stuck. And so this is why the tissues don't get a good elevation. So I went ahead and drew out some X marks to show you where roughly some of these ligaments reside. So this one is called the zygomatic ligament. It's a ligament that sits pretty much, the funny thing is I almost always like to sort of take a measurement. It's almost always 4.5 centimeters from the front of the tragus, which is really interesting. But I know it's there. In fact, sometimes it goes a little bit longer. It extends about a centimeter, centimeter and a half going forward. And so sometimes I've got to go a little bit farther. And my end point is when it's released. This ligament sits again between the SMAS and the deep tissues called the parieto-masseteric fascia. So this is the ligament that has to be released to get proper mid-face elevation. The other ligament is a little bit more variable, sits around this zone called the parieto-masseteric ligament. That ligament attaches also between the SMAS and the deeper tissues. And this masseteric ligament right here just needs to be released so that I can get proper elevation in this mid-zone. A critical elevation or release is actually technically not in the deep plane. It is actually in the subcutaneous tissues called the mandibular ligament. The mandibular ligament, people think it sits right here. It actually wraps all the way around underneath the chin. So when I release this, it's a three-dimensional ligament. It's subcutaneous, has to release all the way around here. Now what's interesting is you'll hear in some doctors, they'll say that if you're doing a chin implant, I release the periosteal attachment down here, and you think, well, you've actually gotten a good mandibular release. You haven't for a couple of reasons. First, as I said, you need to release all the way below the chin. With a chin implant, you're only releasing here. In fact, you don't want to release here because your chin implant will slide underneath. So that's the first problem with the idea that a chin implant release will give you the correct release. The second problem is that deep periosteal release doesn't provide cutaneous release. You really have to release it in the subcutaneous plane. So in other words, just below the skin. I actually forgot to draw out the fourth ligament, which is a critical ligament. And it is right here called the posterior retaining ligament. So posterior retaining ligament, if you can see what I'm touching, is this is the sternocleidomastoid muscle that goes down. I release it about 2.5 centimeters going down into the midsection here. So that's a critical fourth ligament. I was just drawing this out quickly. I'm sorry I didn't draw that out. But there's also this ligament. So it's basically the SMAS or the platysma, which is one unit, is joined to the sternocleidomastoid, and that's got to be released. So those are your major ligaments. Now, I actually do what's called sort of an extended deep plane, which basically means that I actually go into this zone here because there are a lot of minor ligaments that I can actually almost bluntly separate. I don't need to sharply dissect it. These have to be sharply dissected, but I'll feel a resistance give. And so it's very safe because there's more nerves over here, but I'm just using a blunt, what's called a trepsat. I can release these ligaments to here. It's the same thing below the platysma muscle. The platysma is the thing that, when you look at someone aging, you're tying those two bands back together, but it's also being released off the back side of this, front side of the sternocleidomastoid muscle. But I find that not just releasing a few little distance here, and releasing the area in front of the sternocleidomastoid, I actually go underneath in a blunt dissection. It doesn't have to be sharp. It just separates, and when you release those little adhesions, tissues come up really nicely. So there are 4 major ligaments and a lot of small minor ligaments. The major ligaments have to be released sharply. The minor ligaments can be released bluntly. So finally getting to the core, the core of this. High SMAS is, even though the word it says SMAS, high SMAS, it actually is a version of a deep plane facelift. And I'll be very honest with you, the high SMAS results I've seen have been excellent, and the classic deep plane results have been excellent. So the one thing I really want people to understand is that I really don't have issues with people doing high SMAS versus classic deep plane. But I will say I have an issue with the traditional SMAS technique. In other words, if there's no deep plane entry with ligamentous release, then I think that is not as an inferior result. I used to do that traditional just SMAS technique. Listen to my video where I talk a lot more about SMAS versus deep plane. So what I'm showing you here is, this is called Patangi's line. It goes from the bottom of the ear up to about 2.5 centimeters lateral to the brow. This is where there's a frontal nerve branch that comes up in this area. So I go anterior to it to enter the deep plane and then release the ligaments. So it's safer. But the high SMAS, if you're doing this very carefully, you're going to avoid this because this is actually usually a deeper structure. But the high SMAS, the argument in favor of a high SMAS elevation is that by going farther back, you're able to capture a wider area. And that's the proponents of a high SMAS say they get more elevation. The proponents of a classic deep plane says you're not getting anything over here. You want to get closer to the problem, and so you don't have this long stretch of tissue. Picture this. If you have a long stretch of tissue here and you're pulling way back here, and you're trying to get an effacement of the smile line of the jowl, you're having less pull. So I always say get closer to the problem, and this allows me to get close to the problem, still release all the ligaments, avoid any nerve issues, but this is still very safe in qualified hands, so I don't want you to see this behind the nerve and have an issue thinking this is dangerous. It absolutely is very, very safe in skilled hands. So this is absolutely not denigrating this technique from that perspective. But the thing I want you to see is that with the SMAS, the argument is that it captures a wider area. In my opinion, this is all you need, and it's better to get closer to the problem at hand. So hopefully this little description helps you understand the difference between the two. But as I said, I'm a big fan of the classic deep plane or extended deep plane. At the same time, I have absolutely no issues with a qualified surgeon doing a high SMAS technique.